Geriatrics, the geriatric lecture for 5-year students, College of Medicine, University of Sulaimani, 2020. Dr. Mohamed Al-Shekhani. Our reference is Davison, the chapter of Geriatrics, so students can read this chapter carefully. And the first picture of the geriatric section talks about the illustration about the physical examination in geriatric population, and the vision frequently have a decrease in visual acuity, and they wear glasses, and cataract is common, and they have hearing difficulties. Frequently they use hearing aids, and there is wax in the external auditory canal. Frequently they may have postural hypotension, and this is measured by measuring blood pressure in the erector and supine position and the pulse. They may have atrial fibrillation with irregular pulse, and they may have dehydration and edema, and this can be obviously observed by examining the skin for edema and skin turgor. Nutrition may be defective in elderly, and the oral hygiene and dentation may be a sign that this patient will develop nutritional or have nutritional abnormality because of decreased food intake. Also, examines can fall for evidence of weight loss and cachexia, and evaluation of body mass index by measuring the weight divided by the meter square of the height in meters. And you should compensate for the height by measuring the either arm demispan or the measuring knee height instead of the whole height, because the height may be reduced in elderly because of the osteoporosis-induced fracture vertebra. Also, cognitive function should be assessed by the abbreviated mental test, as we mentioned that later, because cognitive abnormality is common in the elderly. Muscle strength and power should be examined, because frequently they have muscle wasting and weakness. Digital rectal examination is important in the elderly to assess the anal tone, because incontinence common, anal incontinence, fecal incontinence common in elderly, and in men it's important to assess the prostate, because prostate enlargement is common. So you should assess prostate size and consistency, whether it is hard or firm, by digital rectal examination, because prostatic enlargement is common, whether benign prostatic hypertrophy or cancer. Also, it's important to assess for digital rectal examination for fecal impaction, common in the elderly as a cause of constipation. Also, it's important to examine the skin, because senile purpura is common in elderly. Also, assess for swelling, infection, fungal infection or other infection, and for wounds and ulcers. Important to examine for the joints, range of movement, swelling, pain, deformity, because paralysis and rheumatoid arthritis may be common in elderly. Also assess for kyphosis, which is common in elderly because of the vertebral fractures. Also important to assess for gait and balance by doing get up and go test, which we'll later talk about, and examine whether walking aid is used by geriatric population. The aging, we consider geriatric usually geriatric when the age is above 65. But biological rather than chronological age should be considered, especially when considering or making clinical decision about appropriate investigation or intervention. Geriatric medicine is concerned particularly with frail or weak elder people, in whom physiological capacity is so reduced that they are incapacitated by even minor illness. They frequently have multiple comorbidities, and acute illness may present in a non-specific ways, such as confusion, falls, loss of morbidity, and day-to-day functioning variability. They are prone to adverse drug reactions, partly because of the polypharmacy and age-related changes in pharmacodynamics and kinetics. Disability is common, but patients' function can often be improved by interventions by the multidisciplinary team, which is very essential in the management of elderly people. Frailty. What is frailty? Weakness. Frailty is a characteristic feature of geriatric population. Frailty indicates increased vulnerability to loss of function. Frailty is the loss of an individual's ability to withstand minor stress because the reserve functions of several organ systems are so severely reduced that even a trivial illness or adverse drug reaction may result in organ failure and even death. This is frailty. While disability is established loss of function. Frailty is the vulnerability to develop loss of function, which may be transient if you diagnose and treat underlying cause. We can assess the cognitive function by abbreviated mental test. While we have many mental state exams for more detailed assessment of cognitive function. And this list, you can assess the cognitive function by abbreviated mental test. And each correct answer score marks 1. The more score the patient have, the better his cognition. And this simple question, what time is it? What year is it? What is the name of this place hospital? How old you are? What is your date of birth? When did the First World War begin? Who is the present governor, for example? Please count backward from 20 to 1. Can you recognize 2 people? Either 2 relatives or photograph of 2 persons. Can you tell me the address I asked you to memorize a few moments ago? So each one has 1 mark, and the more marks he has, the better his cognitive function. Geriatric population should be assessed by a multidisciplinary team, and this team has 7 members: physiotherapist, occupational therapist, dietitian, speech language therapist, social worker, and nurse. And each one has its function in this team, and they cooperate with each other. We assess the gait by get up and go test. This is to assess the balance. Ask the patient to stand up from a sitting position, from a chair, walk 10 meters, turn and go back to the chair. This table illustrates the mean life expectancy in years, comparing UK with India and comparing males with females. And this graph shows the growing number of geriatric elderly population over years and predicted up to 2050. In all features and consequences of normal aging. So all organs of the body are affected by aging. So in CNS we have neuronal loss, cochlear degeneration, increased lens rigidity with cataract, lens opacification, anterior horn cell loss, dorsal column loss, and slowed reaction times. All these will lead to increased risk of delirium, presbyosis, high-tone hearing loss, presbyosis, abnormal near vision, cataract, muscle weakness and wasting, reduced position and vibration sense, and increased risk of falls. While in the respiratory system we have reduced lung elasticity and abnormal alveolar support, increased chest wall rigidity, increased ventilation, perfusion mismatch, reduced cuff ancillary action, and this all will lead to reduced vital capacity and peak expiratory flow, increased residual volume, reduced inspiratory reserve volume, reduced arterial oxygen saturation, increased risk of infection. Cardiovascular system, reduced maximum heart rate, dilatation of aorta, reduced elasticity of conduit capacitant vessels, reduced number of pacing myocytes in sinoatrial node, SA node. This all lead to reduced exercise tolerance, widened aortic arch on X-ray, widened pulse pressure, increased risk of postural hypotension, and increased risk of atrial fibrillation. Endocrine system, deterioration in pancreatic beta cell function with increased risk of impaired glucose tolerance and diabetes. Renal system, loss of nephrons, reduced glomerular filtration rate, reduced tubular function, and this all lead to impaired fluid balance, increased risk of dehydration, overload, impaired drug metabolism and excretion. Genitourinary system, there will be reduced motility, leading to constipation. Bones, reduced bone mineral density, and increased risk of osteoporosis. Comprehensive geriatric assessment. Inpatient comprehensive geriatric assessment reduces short-term mortality and increases the chances of patient living at home in the long term. So important to when elderly are inpatient to have a comprehensive geriatric assessment by multidisciplinary team we mentioned. Decision whether to do investigation in an elderly patient depend on the patient's general health. Or does the patient has physical and mental capacity to tolerate the proposed investigation? For example, does the patient have capacity to undergo bronchoscopy? Will her confusion prevent her from remaining still in MRI scanner? The more comorbidity a patient has, the less likely he or she will be able to withstand an invasive or complex intervention. So, whether to do investigation elder depends on all of these. So first, if you decide to do investigation, depend on whether the patient general health allows to do such investigation. The other point, will the investigation alter management? Would the patient fit or benefit from treatment that would be indicated if investigation proves positive? And in this regard, comorbidity is more important than age itself in this regard. Example, when patient with severe heart failure and all disabling stroke present with suspicion masked on chest X-ray, suggestive of lung cancer, detailed investigation and staging may not be appropriate if he is not fit for surgery, radiotherapy, or chemotherapy. So what is the benefit of diagnosing bronchogenic carcinoma in patients with severe heart failure and old disabling severe, and he cannot tolerate the treatments if this proves to be bronchogenic carcinoma? On the other hand, if the safe patient presents with dysphagia, he will be able to tolerate endoscopic treatment, for example, to palliate an obstructing esophageal carcinoma. He will tolerate the endoscopy and the endoscopic treatment, and you can bypass by a stent this obstructing esophageal carcinoma, and he can eat well and stay in life longer. The third point about decision about investigation, the view of the patient family. If the elder patient wishes to undergo such investigation or not. So this decision should be sought and respected. A patient unable to express a view or lacks the capacity to make decision because of cognitive impairment or communication difficulties, then relatives' input become particularly helpful. And this relative may be able to give information on views previously expressed by the patient. Family should never be made to feel responsible for difficult decision. If there is difficult decision and the patient cannot give consent or views or cannot communicate with him, so the doctor decides according to the best patient's perspectives. The other point in deciding to do an investigation is advance directives. Living wills may be respected by doctors if clinically sound. So these were the points whether to decision to do an investigation elderly. Is the patient general health whether allows this investigation or will be benefit. The other is, will the investigation alter the management? The other, the views of the patient and the family if patient cannot talk or communicate. And advance directives of the patient, the living goals of the patient. We come to the characteristics of geriatric presentation problems. The first characteristic of geriatric presentation is late presentation. And usually the geriatric problem presents late because the patient may accept ill health and say that this is due to aging by the patient or by the relative or even by the doctor sometimes. Attribute all the symptoms to aging, and this is wrong. You should be away from this idea. Not all presentations of elderly complaints are due to aging. And aging may tolerate symptoms before seeking medical advice. Comorbidities also. For example, if mobility is limited by stroke, CVA, angina may only present when coronary artery disease is advanced because patient cannot walk and have exertional chest pain. So first is late presentation, atypical presentation. Infection may present with acute confusion without clinical pointer to organ system affected. And stroke may present with fall rather than symptom of focal weakness. Myocardial infarction may present atypically with weakness, fatigue without chest pain or dyspnea. The reasons of these atypical presentations: reduced perception of pain in elderly, reduced pyretic response, cognitive impairment, and limits the ability to give history of classical symptoms. The third characteristics of geriatric problems is acute illness and change in infection. And this always should be considered and excluded. The other characteristic of geriatric presenting problems is multiple pathologies common. Frequently, there are a number of causes of any single problem, and adverse effects from medication often contribute to this single problem in addition to the illnesses. For example, a fall may be from OA of the knees, postural hypotension due to diuretics for hypertension, or poor vision due to cataract. Domains impaired in frailty. Frailty is weakness of the elderly that cannot withstand even minor illnesses or drugs. These domains impaired are musculoskeletal function, muscle weakness and atrophy, aerobic capacity, cardiorespiratory function impaired, cognitive function, integrative neurological function, balance and gait, and nutritional status. All these domains are impaired in elderly and make them frail and weak to minor illnesses and use of drugs that are well tolerated by youngs. Screening investigation for acute illness in elderly is full blood count, urea, electrolyte, liver function, calcium, glucose, chest X-ray, ECG, general urine exam for leukocyte, nitrates, a positive urine culture, C-reactive protein for occult infection, blood culture if pyrexia. Prevention of falls in elderly. Effective intervention to prevent fall in elderly people living in the community include exercise intervention, assessment, and multifactorial intervention, withdrawal of psychotropic medication, prescribing medication program in primary care, first eye cataract surgery, pacemaker insertion in those with carotid sinus syndrome, and home safety intervention in those with severe visual impairment and in those at high risk of falling. And all this done by multidisciplinary team we mentioned. How we approach presenting problems in elder. These points are very important. Obtain a collateral history. Not always the patient can give history because of cognitive impairment and other problems, and all CVA. So we may take history from a relative or a career. Sometimes call these people by phone if they are not present. Check all medications. Any recent change, search for and treat for any acute illness, identify and reverse predisposing risk factor depending on the presenting problem. We come to the final topic, in our presentation of geriatrics is major presenting problem in older age. We have this major 5 presenting problem in elderly, and we have other less common presenting problem. The 5 major presenting problem in geriatrics are falls, delirium, and acute confusion, urinary incontinence, adverse drug reaction, and dizziness. These are other less common problems: hypothermia, undernutrition, infection, fluid balance problems, heart failure, hypertension, AF, diabetes, peptic ulcer, anemia, painful joint osteoarthritis, fracture, immobility, stroke, and dementia. The first most common presenting problem in frail elderly and geriatrics are falls. Epidemiology of falls: 30% over 65 years of age each year fall. This may increase to 40% above 80 years of age. They may fall each year. 10 to 15% of fall result in serious injury, and it is the cause of more than 90% of hip fracture, partly due to the increasing osteoporosis in the elderly. Falls also lead to loss of confidence, fear, and frequently the final straw that makes an elder decide to move to institutional care. The management of fall depends according to underlying cause. And the causes of falls include, first, acute illness. The classical atypical presentation of acute illness in frail people is falls. Because of the reduced reserve in neurological function, so they cannot maintain balance when challenged by acute illness. Common underlying illnesses: infection, stroke, metabolic disturbance, and heart failure. Thorough examination and investigation are required to reveal these underlying causes. And also, drug may be a precipitating factor of falls, such as psychotropic or hypotensive medications. The other cause of fall is blackouts due to syncopal episode. Ask about loss of consciousness and perform appropriate investigation. The third is mechanical and recurrent fall that require investigation. Those who have tripped or uncertain how they fell, so you should investigate for cause of fall. Those who have more than one fall in the past year, and those with abnormal get up and go test. So those patients who fall especially recurrent falls should do investigation to find the cause. Patients with recurrent fall are commonly weak, frail, with comorbidity, chronic disability, acute illness, or syncope, and they are at risk of further falls even when the acute illness has resolved. If problem identified with muscle strength, balance, vision, or cognitive function assessment, causes revealed by specific investigation and treatment. Common pathology: CPA, Parkinson's disease, osteoarthritis, and osteoporosis. Osteoporosis risk factor should be reviewed, and DEXA, bone density, bone scan can be considered, particularly if they are already sustained a fracture. Multiple risk factor intervention and individualized to specific patient. Most effective is balance and strength training by physiotherapists, assessment of patient home environment for hazards of fall by an occupational therapist, rationalizing psychotropic medication to reduce sedation through, although many elders are reluctant to stop hypnotics. If postural hypotension is present, blood pressure drop of more than 20 mm mercury systolic or more than 10 mm diastolic on standing from supine, this is postural hypotension. Reducing or stopping hypotensive drugs is helpful. New glasses to correct visual acuity and podiatry or food assessment can also have significant impact on function. If osteoporosis is diagnosed in female, calcium vitamin D can reduce fracture rates, reduce falls by reversing the changes in neuromuscular function associated with vitamin D deficiency. For those osteoporosis in the community, bisphosphonates are the first-line therapy. Multifactorial intervention to prevent falls, individual or group exercise training, rationalization of medication, especially psychotropic drugs, correct the visual impairment, particularly cataract, home environmental hazard assessment and safety education by occupational therapists, treatment of cardiovascular disorders, including